Well, ladies and gentlemen, as it is now 1 minute past 6 p.m., I am very happy to welcome you to this next EHAD Academy webinar. And this is one of the webinars with a focus on hemophilia gene therapy. I am Michiel Coppens. I work as an adult hemophilia doctor in the Amsterdam University Medical Centers. And for today, we have the focus of this webinar today would be update on the durability in gene therapy. Before we go to our presentations, on the next slide, you find a QR code. Bear in mind, feedback on these webinars on the topics of the content we are sharing with you is highly appreciated and really shapes how we would like to do the next webinar. So I would highly encourage you to use it. The questionnaire is already open. You can start it on the go and fill it out during the webinar. And maybe just shortly, because then it has these nice pictures. Juliana, if you just move one slide back, sorry. Well, oh no, this one actually works out just as well. Sorry. Because I was then saying what we have planned today is that we start with Simon Fletcher. We try to take the patient perspective on the on durability. I will follow up with Simon with the quite hard task of trying to explain the mechanisms of the loss of expression after gene therapy we have seen in some of these trials. And then Robert Klamroth will bring it all together with sharing, first of all, the latest durability updates from current studies, as well as some, well, let's call it real world evidence from Germany where he practices. So with that short introduction, I'm very happy to hand over the mic to Simon Fletcher, and I'm really interested in hearing what you have to say about the patient perspective. Simon, go ahead.
Thank you, Michiel. I'm really pleased to be here this afternoon, and thank you for inviting me to speak. I'll just briefly introduce myself, as many people may not know me, but I'm a nurse by background. I've been working in bleeding disorders care really for about the past 10-15 years, and I'm also working currently at the University of Oxford on their cardiomyopathy gene therapy program there, looking in particular at patient preferences there. So many of the things that I'm going to talk about here translate across there and vice versa. So these are my disclosures. Hopefully a moment ago it was all working, but here we go. There we go. Bit of a lag. Sorry, I'll go back to that. So there's not very much there of any relevance. The aims and objectives of the talk this evening is to just look a little bit at what gene therapy durability actually means. Why does it matter to patients? What concern patients may have about durability, and how might durability shape the future of treatment decisions for them and treatment decisions really for those companies and who are involved in gene therapy per se. So it's really important to not just think about durability, but actually think about variability as well. I think sometimes the two are so interconnected. It's really difficult to talk about one without the other, and I won't really go into the figures because I know Michiel and Robert will be going into those a bit more later. But you know, we have seen the fact that some people have gone to have been normalized following gene therapy. Some even gone super normal levels, but some have had more modest rises. And if you think about where you start is always going to be important for where you're going to end up in the long term. So it's always important to think about that. And it's also important to think about actually and to remember that the durability of gene therapy for haemophilia A and gene therapy for haemophilia B is very, very different. So in some senses, you're talking about two very different processes and two very different stories in terms of durability per se. So to define durability, what do we actually mean by it? Do we mean factor expression levels over time? And there is a tendency, I think, for patients to think about levels because we've always taught them to think about levels. And I've heard from many patients when they come in for their visits for follow-up for gene therapy, they're going, "What are my levels? Are they higher? Are they lower than they were last week? Are they higher or they're lower than they were a month ago?" If they're higher, they're always happy. If it's the same, they're always okay. They're the same. It's not got any worse. If it's lower, then there's always this concern. But do we think about bleeding rate reduction and maintenance of that? Do we just turn around and say, actually, your levels don't matter as long as you're not getting bleeds, we're happy? And I think there's a balance to be had between the two. I don't think it's one or the other. I think it is this balance in the middle, and we have to kind of push that whole thing there. But why does durability matter to patients? Because they're the ones that are going to be investing in this in the long term. If we don't give them the information that they need to make the decision to be able to go into gene therapy or to have gene therapy as a treatment option for them, then actually nobody's going to be doing it. And we're kind of seeing a little bit of that at the moment. Some patients are turning around and saying, well, I'm waiting for more data to be available. I don't want to go into a study at the moment. And we're in a catch-22 situation. If we don't have people go in to do the gene therapy, we're not going to get the data. Therefore, they're not going to get the data to make the decision as to whether they want to go into a gene therapy process. So it really is a very, very difficult catch-22 situation that we're living in with them at the moment. So I think there are three main durability concerns from a patient perspective. The first is expression decline, and we need to really address that in terms of, is it going to be gradual, is it going to be sudden, and patients really want to know this. What are the warning signs? How do they know that actually the durability of the treatment isn't as it was? They are now are they getting bleeds, that sort of thing? What are the monitoring protocols? How are we going to keep an eye on them? How are they going to inform us if they've got any problems themselves? And the threshold for intervention. I think it's really important to remember that actually a severe person who's had gene therapy is not going to be the same as somebody who's had moderate or mild haemophilia for the whole of their lives. They've got a significant amount of joint damage because of the severity of and the bleeds that they've had over the years. So somebody who has a level of 8 or 9, you would normally say shouldn't get a bleed day to day. But actually somebody who's been severe, who's had gene therapy and has a level of 8 or 9 and comes in with pain in their knee, actually we need to look at, it may not be a bleed, but it may be a bleed. And where do we hold that threshold for starting intervention, and what do we do with that? And another concern is pretty much uncertainty. As I said earlier, there's this catch-22 situation where patients are waiting for the data to be available, and there isn't the data available. We're still early days in terms of gene therapy. So how do people who are looking at gene therapy navigate this unknown? And decision making with limited long-term data, as I've said, balancing hope with realistic expectations. Some of the patients that I've spoken to have said, "Oh, well, after gene therapy, I can live I can live normally. I want to go into the forces. I want to go into the police." And actually, is this a realistic expectation that they have? And how do we manage those expectations? And what support systems have we got in place for them? Not just within the haemophilia care system and setting, but also further than that in terms of their local support groups that they've got available in their own countries and everything there. And retreatment is the big thing for some people. They're aware that actually this is a one-time only thing for them at this point in time. we've got these limitations on retreatment in terms of the viral vectors, the immune response that we have to them. Future treatment options after gene therapy is a concern as well. It's like, well, if it doesn't work, if it doesn't work or it wears off over time, what happens? What will I be able to go on? Will there be elements of the gene therapy that mean that I can't go on certain other treatments that other people are getting? So these are questions that they're asking that I'm hearing. And there's this need for contingency planning as well, to talk with them and make them understand, that actually there are unanswered questions that we still have at the moment, and we still need to go on and think about those. So it's really important to improve communication. Patient education materials are really important, and I think we all need to be involved in getting those as tip top as we can, actually. And the informed consent process, there's a lot of talk about shared decision making, and it can be a slow process, but it needn't be a slow process. It just needs to be a process that takes as long as it needs to take for them to make a decision, yes or no. Long-term follow-up programs, we know that they're going to need to be followed up for a long time, and they need to be aware of this and just what that involves. And as I say, psychosocial support is really, really important. We need to be providing it for them to help them deal with the situations that they may have to go through if it doesn't work at all, if it works but not to a level where they thought it was going to get them, and to deal with the expectation management that comes with gene therapy as a whole, I think. So future directions, as I said earlier, we are looking at a situation at the moment where it's a once in a lifetime treatment, but actually that may not be the case in the future. There are emerging gene therapy approaches with heightened focus on durability and on redosing. Many are beginning to look at other viral vectors, lipid nanoparticles, artificial particles even as well. So there's a whole different raft of treatments that may be coming along that mean that actually in the future this isn't once only in a lifetime. There may be more there may be more options in the future, and it's important as well that we talk about long-term patient registries as well. We've got EHAD registry, we've got the WFH registry. It's important that we get these registries up and running fully, so that we actually get the information that we can then feed back to the patients and saying, this is the data that's coming out of the studies, this is the data that's coming out of those people that have had it as a treatment, so that we can actually break that catch-22 situation, so that there's information for them to be able for them to be able to make the decisions that they want, and the ongoing role of organizations in setting goals and providing support for people going through that. So on that note, I would like to say thank you, and I'll be taking questions with everybody else at the end. And if there's anything you want to ask, then please ask at the end or put it in the chat. We'd love to answer it at the end. Thank you very much.
Well, thank you very much, Simon, and a great first kickoff to this webinar. Our questions will be at the very end, of course, and I will try to explain some of the mechanisms behind the loss of expression that has been seen after AAV gene therapy. Like Simon, unlike Simon, actually, I do have a couple of conflicts of interest, which you can show here. I'm basically here having experience in gene therapy trials. Across 3 trials, I have now dosed 9 patients collectively in HEM-A and HEM-B, so that's where my experience comes from. However, in my country, the Netherlands, as yet, gene therapy is not reimbursed yet, so there is no real-world experience yet. So basically, I think most of us will know that haemophilia gene therapy, which uses the adeno-associated viruses or adeno-associated viral vectors as the vector to introduce the transgene into the nucleus actually does not integrate. It does not integrate into the chromosomes, and it is still regarded as one of the key safety features of AAV gene therapy. So what happens to the DNA? It's actually put in small circles in the cell's nucleus, and those small circles of DNA we actually call episomes. So what should one expect from an episome long term? Well, interestingly, and Wikipedia is always kind of nice when you open it up because it regularly gives you additional insights. Well, an episome is kind of a plasmid. A plasmid is like a small circle of DNA, but with the key features actually that the DNA that is in the episomes is also, upon cell division, like all the chromosomal DNA, is also copied and basically put in both daughter cells of the dividing cell. That's the official sort of definition of an episome. So, and also it also should not degrade, like as it says, like unlike standard plasmids. And well, I've been in gene therapy for quite a while now. I only looked at this definition quite recently, and actually this is not the common sense that people have with gene therapy. If we all think, and that's where I came from originally, is that these small circles of DNA may actually be lost upon cell division. Will it end up in one of the daughter cells, in both daughter cells, or even in none daughter cells? So I think the hypothesis originally was that upon subsequent cell division, there's a realistic role of diluting out the gene therapy and basically losing expression. But then I guess the big surprise was the incredible stability we have seen in, I think, still one of the first landmark trials. What you see here is a presentation at ASH 2022 by Professor Amit Nathwani, who basically was the principal investigator of this, well, unique landmark St. Jude University Colleges London haemophilia gene therapy trial. And what he shows here in this slide, this is the phase 1/2 study, is no less than 12 years of complete stable factor IX expression following gene therapy. And I guess, as a doctor a few years ago, this was the biggest surprise to me, that gene therapy could be extremely stable. Well, essentially, there can be two explanations. First of all, it could actually be that adult hepatocytes are rather dormant and, in fact, have hardly any cell turnover. And by definition, there is no risk of diluting out the gene therapy. And in fact, this is, as I'm being told by hepatologists, the human liver, unless you get like a partial hepatectomy or something like that, is actually quite a dormant tissue and does not have a lot of cell turnover. However, it could also be that the episomes introduced by gene therapy are in fact true episomes, that the DNA would be transferred to the daughter cells upon cell division. Well, does this matter? For an adult patient, it may not actually matter that much, and it will be quite hard in real practice to actually disentangle the two, but the consequences are quite significant if we are at some point considering bringing AAV gene therapy to adolescents and maybe even to younger children who have, by definition, a growing liver. But the word, I guess, is still out. In contrast with this huge stability in factor IX, a few years already ago, we saw the transient expression observed with phylactocogene roxaparvovec, the first registered hemophilia A gene therapy. And what is the typical picture? This is the 4-year follow-up of the patients in the phase 3 trial, is that it peaks around month 6 and then it starts going down. And I think the discussion is still out there if this stabilizes out, maybe, hopefully, perpetually in some of those patients, or whether it will eventually lead to a full loss of expression given enough time. I think when I saw these data at the 2-year follow-up, I was sort of skeptical, actually, that this could really be leading to really long-term expression. However, I have to say that with increasing years of follow-up and now this 4-year follow-up, I have to say that the tail of this curve is looking rather stable. So that gives hope for those still having achieved expression at the very tail of this curve. However, what we need to realize that in the end, until recently, there was just one phase 3 trial in hemophilia A. And so basically, it's a pretty tough claim to say that this is really disease specific. It could also be product specific. And yes, there are phase 1/2 studies, and maybe they allude to the fact that it could in fact be disease specific, but it's, well, quite hard to interpret with all the different doses, regimens going on in phase 1/2 trials. However, until recently, it seems that this question is now better settled. On the right side, you see there are now 2 phase 3 hemophilia B trials, etranacogene desaparvovec and fidanacogene elaparvovec. And the expression graph in terms of stability over time looks rather the same. These are both 2 and 3 year follow-ups, and what you see, rather a copy of the Amit Nathwani study. It seems very stable expression over time. On the left side, we see hemophilia A. The top one is the valoctocogene roxaparvovec. And at the bottom, we see the first new hemophilia A phase 3 gene therapy that was first presented at ASH 2024. And this slide comes from the EHET 2025 presentation. And it now shows that, like the valoctocogene picture, there is a peaking of the factor VIII expression after 6 months, going down with a sort of similar discussion whether it stables out or whether it would lead to long-term loss of expression. So overall, I think the question is almost settled, or more or less settled, that it does seem disease-specific loss of expression. So if we talk about loss of expression after AAV gene therapy, for me, it's important to distinguish 2 forms. There is one that is associated with a rise in transaminase level, usually the ALT level, and which is typically an early loss, typically occurring within 3 or maybe 3 to 6 months, and in which the loss of expression is rather swift, over days to weeks loss of expression. That needs to be distinguished from the loss of expression not associated with an ALT increase, which is typically a later, after that 6-month peak you have just seen in the hemophilia A trials, which is not associated with ALT and goes down much more gradual over time, and may or may not end up with a full loss of expression and going back on prophylaxis. And for the remainder of this webinar, I'll try to explain some of the mechanisms between the 2 forms. This is essentially the case that shaped gene therapy trials thereafter. This is a very early hemophilia B AAV gene therapy trial, and first focus on that panel on the left bottom side. This is a patient, the red line is factor IX, who initially achieved expression, but at week 4 you see his ALT and AST level going up. And a week later, you see a serious decline in factor IX expression, and that factor IX expression was fully lost over the course of the next few weeks. This was the first time this was ever observed in humans. So basically, they suspected by the timing that it could be immune response, but basically it didn't have the materials in that patient to convincingly prove that. But they changed the protocols, and in a subsequent patient that also showed an increase in an ALT, they were able to do the additional testing and to actually rather convincingly show that it was a T-cell mediated cytotoxic response towards the capsid, the AAV capsid. So not in fact to the transgene, but the AAV capsid that brings in the transgene. And this study ended with the suggestion that future studies in humans may require immunomodulation. Well, of course, that is then what happened. And here, first of all, this is basically the same thing, graphically showing you again. On the left-hand side, the green one is the AAV gene therapy. The therapeutic gene, it infects basically hepatocytes. The therapeutic gene is put in the cell nucleus, and over time those green little balls, which are the AAV capsid, can be presented by antigen presenting cells to our immune system and may lead to selective elimination of transfected hepatocytes and loss of expression. So, as I said, it may require immunomodulation, and this is again that landmark Amit Nathwani study with the long follow-up duration. And this is where they first attempted to treat patients with an ALT increase with corticosteroids. And I think this is a patient that actually showed that the ALT levels is going up. That's the line in green. At the same time, in this particular patient, it seemed that factor IX was already going down. He was put on a high dose of corticosteroids, 60 milligrams, and then the ALT levels went down and the factor IX activity went up again. So seemingly salvaging the loss of expression, the immune-mediated loss of expression. Well, after this success, this then became the standard for basically all gene therapy trials using AAV. So what is it? Well, these kind of immune responses should typically arise within basically the first 12 weeks, but I think there is some leniency to say it could also be the first 12 to 26 weeks. This is the reason why all gene therapy protocols have very stringent follow-up, why people need to come in weekly for ALT checks and checks of the factor 8 and 9 expression weekly for 12 to 26 weeks, depending on the product they have been infused with. And the reason for the screening is to trigger swift installation of corticosteroids when the ALT levels are going up. And basically, this is all part of the SMPC, or you can find on the EMA website, but that's really the shortest version basically there is. So now there is also really recently published a practice guidance paper that basically, well, helps the clinicians that need to work this corticosteroid protocol and the screening of livers upfront before gene therapy is now available. And I can highly recommend to read that, basically, especially if you will be starting or considering to start gene therapy. However, is it that simple, like a simple immunological response that is responsive to corticosteroids? Well, I guess, of course, it isn't. The most striking thing is the incidence of those ALT increases. And what you see in the table on the left hand are those 4 phase 3 gene therapy trials. And the latest before one column basically says the incidence of patients with an ALT increase, with huge variability, varying from 20% to 86%. And there may, well, if you look between the hairs of your eyes, it actually seems that that incidence could be slightly higher in the hemophilia A gene therapy trials compared to the hemophilia B gene therapy trials. So overall, taking into account that these vectors may be different subtypes, but are largely similar, it would be surprising that this incidence ranges from 20 to 86%. So I think it immediately opens up the potential of maybe non-T cell mediated immunological ALT increases. And if there are such alternative mechanisms, I think it's very important that we start to getting a grip of, well, to disentangle those that actually would require treatment with corticosteroids from those that would not require corticosteroids. However, and that's important to state, in spite of the uncertainties, what's causing that ALT increase, we do have to say that it seems that the current protocols actually do work. Those ALT events are more than 90% of patients are ultimately classified as rather mild. And by swiftly installing corticosteroids, the loss of expression seems to be prevented in most, if not all patients. The real cost price is essentially that prednisolone generally can generate side effects, which are bothersome, not per se dangerous, but are significant, and especially with the high dosages used. And depending on the different gene therapies used, the duration of prednisolone is actually quite long, with medians of 3 to 6 months, depending on the different type of gene therapy. So this is one of the interesting things. There are, of course, gene therapy trials that have never gone into phase 3 and have now been terminated. And sometimes our best lessons are in the failures. This is the BAX 335 hemophilia gene therapy. It was always one with high attention because it was actually the first one to use the factor 9 Padua gene instead of the factor 9 wild type gene, which immediately showed the potential of higher factor activity with hemophilia B gene therapy. But there was a significant problem. 8 patients were dosed, and 7 of those 8 patients completely lost factor 9 expression. There were similar protocols in place, and in spite of some patients being treated with corticosteroids, the factor 9 expression loss was actually not prevented. So what did they do? They actually did some very interesting further additional studies, and they actually showed that in that study, it did seem to be a cellular immunity reaction, but not against the AAV viral capsid, but actually involving codon optimization. In fact, if you have a lot of CpG sequences in your gene cassette, that may actually trigger that immune response. And maybe that could also explain some differences between hemophilia A and hemophilia gene therapy. Hemophilia A gene, the factor 8 gene, is a rather large gene, which needs to go, well, as much as of optimization and cutting down in size to actually fit into an AAV particle. And maybe there is more codon optimization in hemophilia A gene therapy than there was in B. Speculative, of course, but an interesting theory and an alternative to immunity to the viral capsid only. And indeed, there is some, in fact, evidence from other angles as well that basically, if you have a CpG depleted AAV vector, you may evade that immune detection. So definitely something to direct future developments of the actual gene cassette. So as I said, from failures come some of the more interesting lessons. Wrapping up the immunological T cell mediated loss of expression. Well, as I repeat, it can be managed by protocols. It are intense short-term follow-up durations of 3 to 6 months, with hugely varying incidence, which is a problem in trying to understand what it is. However, it seems successfully manageable with corticosteroids. For me, the two true challenges are, as I said already, to identify the true immunological ALT increase that requires steroids and to separate those from non-immunological ALT increases that would not need corticosteroid treatment. We need biomarkers, we need predictors of that, and we don't have that currently. And also because prednisolone is simply a drug with quite a number of side effects, there are immunomodulatory drugs that have less side effects, which should, for a T cell reaction, work just as well. And I think we want or need those alternatives to corticosteroids, but they have at this point been insufficiently tested to really treat a patient differently. Then trying to move, I need to be honest, to the late loss of expression. So a different picture. This is a gradual loss. It does not occur over days to weeks. It occurs over weeks to months or even over years. Generally, it's not related to any ALT increase. And this is where we started my talk in the webinar, where we see a huge disconnect between hemophilia A, where it typically occurs, versus hemophilia B, where there does not seem to occur at all, with the flat lines in the follow-up. So the million-dollar question is, why the hell are we seeing those differences? Well, I cannot give you any conclusive answers. I can just give you theories and hypotheses. It starts with highlighting differences between Hem-A and Hem-B with respect to gene therapy trials. Gene therapy, AAV viral vectors actually target hepatocytes within the liver. And although most coagulation factors, also factor VIII and IX, are produced in the liver, it's actually not the hepatocytes doing all the production. Yes, hepatocytes are the native site of factor IX production for hemophilia B, but factor VIII is not produced in hepatocytes, it's actually produced in liver sinusoidal endothelial cells. So what you are doing with AAV gene therapy is that your AAV hemophilia A gene therapy is that you're transfecting hepatocytes and more or less using their machinery to produce factor VIII, but essentially it's not something that they have been born to do, if we may call it that. But still, that's an apparent difference, and everybody feels this could be a possible explanation, but then how would that lead to loss of expression? And that's still the big question. One of the leading hypotheses is that actually factor VIII expression would lead to like a stress response in the endoplasmatic reticulum. And in fact, in the endoplasmatic reticulum is where a lot of the post-translational modifications take place. After translations, you have long chains of amino acid, but to become factor VIII, they need to be folded and in a three-dimensional structure that actually works. That is done in the endoplasmatic reticulum. And in fact, in this study, in the cell study, they actually showed that when they increase factor VIII synthesis in the ER, cellular stress occurs, and it actually leads to amyloid-like fibrous crystals being put down in the endoplasmatic reticulum of those hepatocytes. So, and indeed, they already suggest this could actually be a mechanism for maybe loss of expression, but also similarly for the other short-term loss. This could actually also lead to cell loss and maybe an ALT increase as well. So this is one of the hypotheses for both, I guess, long-term loss as well as short-term ALT increase, potentially also with loss. This is the other one. This is, to me, highly important. This was at EHAT 2024 in Frankfurt, and this was in the BioMarin valoctocogene roxaparvovec study. They actually presented the results of liver biopsies in patients that underwent gene therapy. And in the phase 3 gene R8-1 study, 4 patients underwent those liver biopsies. And there were 2 patients were potentially the most important of all there because they were 2 patients with an almost full loss of expression. One coming from 45%, the other coming from 27%, both going down to factor VIII activity lower than 3%. So basically what they did, they went into those biopsies and they actually found that the vector DNA, those episomes in the cell nucleus, were there. The hepatocytes that were transfected were simply there. They were not lost. They were not selectively eliminated by any immune kind of response. However, what they did show, moving from DNA to RNA, the RNA levels were much lower. So in fact, what leads you to conclude that these transfected cells are not eliminated, but somehow the transcription to RNA and then to production of protein is reduced. And in fact, we know this phenomenon. This is what we call epigenetic gene silencing. And I think the big question still is what actually triggers that epigenetic gene silencing. And I think, well, that's where the stress comes in again. It could be the cellular stress. And if so, could that be induced by actually hepatocytes having to produce factor VIII, which they were not born to do, designed for? And then, of course, the big question is, would such processes be preventable? Well, it may be. There are some, with respect to the cellular stress, there were some compounds who are actually able to prevent that. And I think it's still a very long way for that to come into any form of treatment for humans, but it does open a door that maybe such epigenetic silencing could be preventable long term. So wrapping up my part, the late loss of expression really does seem specific for HEM-A. It's gradual, no ALT increase. And I have to say, in spite of what I've told you, these mechanisms are highly speculative. I think I like the hypothesis for epigenetic silencing, but then again, this is based on 2 patients with loss of expression, can be improved upon, and the cellular stress hypothesis is even a further stretch. I think overall everybody feels this explanation being transfected into non-endogenous tissue is plausible, but we should realize it's really hard to prove. Overall, I think we are in need of predictors of loss of expression on the longer term, and we really need that information to help patients guide whether or not they are suitable candidates for gene therapy. And I will end, and I think, Simon, I really like the comment you made, because you actually said it's sort of a catch-22. Some people want to sit at the back of the bus, but to see what else happens. But if none other people among that bus are actually getting or getting the gene therapies, we may not get the answer. So it is about talking about to patients, but I think we need to really discuss, and of course this needs to be voluntary, that if we see patients with strange losses of expression or maybe with strange ALT increases, we should counsel them whether or not they would be willing to surrender a liver biopsy, enable to hope to break further into the real causes of this loss of expression. And with that, I'd like to thank you for your attention and then give the last part to Robert.
Yeah, thank you, Michiel. So we will continue with real-world evidence, and there are a lot of open questions. You heard it already. There are patient expectations about the durability of gene therapy. We have loss of expression, especially in hemophilia A, which we cannot explain completely. Nevertheless, gene therapy is licensed, and we have to go forward with this. Here are my disclosures. It's mainly for speaking and consulting for companies who are working in hemophilia and coagulation disorders. So let me start with gene therapy is highly regulated in Germany. And if you see on this in a positive perspective, this should ensure the best treatment in our patients for durability and success of gene therapy. On the other hand, for the hemophilia treatment centers, it's a lot of administrative effort. And we need a permission according to the Advanced Therapy Medicinal Products Regulation guideline, which is quite in line what we proposed at EHAD and on a national level, how we conduct gene therapy. But of course, every center has to apply for this permission to do gene therapy. Hub and spoke centers are established in Germany. It's an outpatient treatment. It's an outpatient pharmacy. You need standard operating procedures, and you need participate in the German registry, which I think from my point of view is useful and mandatory. Nevertheless, it might be one reason that gene therapy in Germany is still not well established. And I showed you this number already in the beginning of this year, so not a lot changed because there are still only 4 patients treated in Germany with Valoctocogene or roxapavovec. These 4 patients are treated in my center in Berlin, 2 in 2023, where we at least have some real-world evidence about the first little bit more than a year of durability. And 2 other patients are just treated in January, where I can say nothing. For treatment of hemophilia B, where the perspective of durability is much better, what we heard already from Michiel, there are still 0 patients treated in Germany. And the reason is not that patients are not aware of this option, and there are enough patients who still say, yes, I would give it a try to do gene therapy, but the financing of gene therapy, even in a healthcare system like Germany, is quite difficult. And we expect now finally, after nearly 2 years, that there will be a final negotiated price available in the 1st of April this year, that treatment for patients with hemophilia B is possible. So, of course, if we discuss now durability, we have to look at the clinical trials. And Michiel started already to look at the clinical trials, and I want to go a little bit more in detail, because in the discussion with the patients, that is the best information we have now for durability in the licensed product. For the phase 3 trial in Valoctocogene roxapavovec, we have the 4-year data published. For the phase 1/2 trial, we have 7-year data available. And for hemophilia B with etranacogene dezaparvovec, we have 4-year data from the phase 3 trial. and 8-year data from the phase 1/2 trial. And of course, we can try to make some extrapolation about durability from this trial data. If you look now over for the 4-year data, you can say in summary, for the group of patients, gene-free therapy, even hemophilia A, is quite successful. You see a great reduction over 4 years in ABR, and if you look of the participants with 0 treated bleeds over the years, it's more than half of the patients, even after 4 years in this a period after gene therapy where no treated bleed occurred, which I think is quite successful, especially if we compare this to other treatments. So in summary, we can say from the phase 3 trial, durability for 4 years is possible. This was already shown by Michiel. You can see the factor VIII expression over 4 to 5 years, and it might be different, and Simon mentioned this already. Of course, the factor VIII level gives us some information about protection, but this factor VIII level might be different in individual patients, and some patients do very well with an activity in the mild range above 5%, and some do less well. In the end, and Michiel referred already to this, for hemophilia A, it's quite typical that we have a rise in the beginning and a plateau in the end. So there are still, from this data, the possibility that expression plateaus at some point, and we will have a longer expression than 4 to 5 years in the mild hemophilia range. Variability is a problem, and you can see here, if we look on the median activity in the one-stage clotting assay, you see that it drops a little bit over time. Still, the majority of patients is in the mild hemophilia range above 5%, but more patients have the loss of expression. So in year 4, 10% have a factor VIII expression below 1%, and there are several patients who have a factor VIII expression in the moderate range, which I think below 5% is below our expectations, what we want to reach for our hemophilia patients. So if you look now which patients had to return to prophylaxis, and 24 out of the 134 patients returned to prophylaxis after gene therapy. So on the individual level, it's difficult to say upfront in which category you will land in the end. If we look now at the phase 1 data, and you can see here now over 7 years that gene therapy in this cohort still works with a reduction in ABR over time. And these are the both dose cohorts with 6 times or 4 times 10 or 13 vector genomes per kilogram body weight, where especially in the higher dose cohort, there's still an effect. If you look now at factor VIII levels, you can see that even in year 7, there is some kind of expression of factor VIII. So what can I tell my patients now who want to go for gene therapy for hemophilia A? And of course, there are assumptions. And with these assumptions, you can predict the long-term treatment effect. And based on assumptions and the data from the phase 3 and the phase 1/2 trial, there might be an effect for 11 to 70 years on average. But that depends, and you can see it on the graph, depending on the assumptions you do, that could be lower, 7 years only, or it could be longer. And so we still have to wait for the ongoing publication of results from the gene therapy trial to get more security about the durability of gene therapy in hemophilia A, which is quite clear from my point of view that you have to, can you say to the patients, it's not lifelong. So if you start gene therapy at a younger age, it's not lifelong. There will be decline. It might be 11 years, it might be 7 years, it might be shorter or longer. And of course, from a patient perspective, for a lot of patients, that is not sufficient. And these patients in my center who went for gene therapy say, okay, I will take this risk. I invest this, I will take the risk. and I take the outcome as it comes. If you look now at hemophilia B, and this was already shown by Michiel, so here the curve is quite different. So we have quite a constant expression over 4 years in the HOPE-B trial, in the data presented at the last Congress. And even if you look at the values, they are quite close together. There is a certain range, but the range seems to be lower than with hemophilia A, and there are a lower number of patients who return to prophylaxis. If we see here this graph over the 4 years, the factor IX activity, you can see that still most of the patients are above 5%, are in the mild range of hemophilia A. There is the majority of patients above 25%, and still some patients above 30%. And if you look at the dots for the factor IX expression, it seems in this HOPE-B trial quite consistent over time. And looking now at this results, of course, in a reduction in spontaneous bleeds, in all bleeds, and in joint bleeds. So it's clinical effective. If you look now for the phase I trial and the St. Jude trial, and they used more or less the identical transgene with different AAV capsid, and that was already shown by Michiel that over time, in the phase I trial, with the wild-type factor IX, we have for over 8 years now a constant expression, and nearly 14 years with the factor IX activity in the St. Jude trial. So I agree with Michiel and was previously said, in hemophilia B, the probability of a stable expression more than 10 years is most likely. So there are some extrapolations. They did it before and they estimated up to 25 years. Now there's a new publication underway. There is a certain variation accepted, but I still think in hemophilia B, we can, in the discussion with our patients, at least expect that there will be, if it works, an expression about 10 years or more. So if you look now at the first real-world evidence in Germany, you can see we dosed 2 patients in 2023. So the factor VIII expression in the first patient after 19 months is 17%. The second patient after 60 months still have a very high expression of 286 in the chromogenic assay. He's doing very well without any bleeding, you can imagine. And I would expect that for him, durability will be quite long. So the estimated durability in hemophilia A might be 11 to 17 years. The individual durability for the individual patient is unknown. So we have no personal prediction. It's always on the group level. The estimated durability in hemophilia B might be 10 to 30 years, but again, for the individual patient is unknown. And that makes the discussion with the patient quite difficult. And maybe we can discuss it now a little bit further, and thank you for your attention.
Yeah, Robert, thank you. And while the presentation will be closed down, this opens up the last 5 minutes, which is essentially for you, the audience, to come up with questions as you have them. And of course, take your time. And it's also not necessary to have questions. And I'm more than happy to start with a few to open up the discussion together with Simon and Robert. Simon, and I really liked what you told, that in this follow-up after gene therapy, there may be like an over-focus on factor activity. And as you said, well, the patient coming in and asking, what is my factor level this week, is something that could have happened in my clinic a number of times. And to some extent, I have to say, it actually may be the doctors that have put that in their brains as much as the patients themselves. However, there is always this question, how realistic is the expectation management? And I was sort of struck by one of the remarks that said, well, if I can get a break for just 10 years, that would be nice. What does that say? Is actually 10 years then still the minimum duration of, well, loss of prophy you would need? Or well, because 10 years is already quite a lot in some of those HEMA studies.
Yeah, 10 years I think is a good starting figure. I think it's different for everybody, and it's different for different age groups as well. For somebody who is in their 50s, 10 years without prophy takes them into their 60s, and they can think, actually, that's really, really good for me. Somebody who's 20 could think, 10 years, that's nowhere near enough for me to actually think about this as a realistic option for me. I would need 20, 25, 30 years before I would think about it.
If it were less than 10 years, would you think most patients would have a consensus? Well, if it's less than 10 years, I'm not going to start.
I think some would. I think there are a number of altruistic people out there who think, actually, if I can get 5 years, then it gives people enough data for somebody else in the next generation to get 10, 15 years. It's different for everybody, I think.
Yeah, I think you're right. And what was one of the most vivid testimonials I've ever heard was basically, again, Professor Amit Nathwani telling us that the patient he first dosed in that study realistically had an expected expression of 0. And still he signed up. And before signing up, he actually made a first will. So I think it shows that some of these people, how altruistic their motivations are. Robert, do you, well, use dare to coin that maybe 11 to 17 years in your outpatient clinic already when talking to patients?
No, because durability is the variability is too high. So we don't promise anything, and that's the discussion. And of course, it's a little bit different from a clinical trial, because in the clinical trial, of course, a lot of patients do it for altruistic reasons, and then now it's a clinical trial. Now it's an available treatment option, and you heard already, it's a lot of shared decision making, and of course we have other treatments which more or less have the same results concerning reduction in bleeds. And so I think at the moment, these patients are still some kind of pioneers. And the main motivation is to get rid of any treatment, at least for a period of time. And even our study participants, we dosed in clinical trials, and one of these patients returned to prophylaxis after 2 years. He still said he did not regret the participation in this clinical trial.
Yeah, I think it tells us a lot, and I think we have all had similar, quite remarkable experiences. There's a few questions in the Q&A, and maybe can I direct this one first to you, Robert? This concerns the amyloid findings in factor VIII overproduction, maybe in non-endogenous tissue. Could this influence also amyloid formation in other parts of the body, especially the brain? Could that say something about malignancies?
Oh, that's an extremely difficult question, and I have to say I don't know. And that's the reason we have to monitor all these patients extremely closely over time. And of course, any new malignancy in this patient population have to be really, really well looked at. And so far, at least, we have now hints that there is a causal relation. But of course, it's a new treatment. We have no long-term experience, and that is, we have to be alert. And that's the reason to include, and the reason in Germany why it's mandatory to include these patients in registry to have long-term follow-up.
Yeah, I completely agree with you, Robert. And maybe adding, I think AAV gene therapy, it's not only the gene cassette, you actually have a liver-specific promoter, and the amyloid formation would be a consequence of factor VIII production. So I'm assuming that with the AAV gene therapy, it should not realistically lead to any forms of factor VIII production in the brain, and hopefully, therefore, the risk of amyloid formation would be low to absent. I'm just checking to see in the chat whether or not anything. Well, there's a question whether or not the webinar can be watched a second time, and maybe that's my cue to wrap up. Yes, indeed, this webinar will be part of the EHAD Academy, where basically it can be looked back. What I didn't show you, there's also the EHAD gene therapy repository, where actually doctors can find all that we can collect information regarding current gene therapy trials. Thank you very much, Juliana. Here is the QR code, which leads you to that one as well. And at the very final slide, I again start with almost where I or end where I started, with asking you for your feedback. We really listen to that feedback, and this shapes our next webinars and how you feel about us. And with that, I would very much like to thank the speakers and thank you all for joining this webinar, and hopefully until some next time. Thank you very much. Enjoy your evening.